Wow.
Yeah, so hello everyone. Welcome to Rehabilitation Sciences Group. And now we have a very eminent speaker today, the Kosmas, and he'll be sharing on his views on foot and ankle function and dysfunction. So welcome you all on this platform. We have Dr. Sagun with us, and he'll be formally request him to formally introduce Kosmas on this platform. Please, Dr. Sagun.
Thank you, Dr. Dharam. Good evening, everybody. From my country, from our India, we welcome Kosmas on the Rehabilitation Science Group. We are thankful to him. Within a short span of time, he has given his consent for this lecture. Kosmas did his physiotherapy from the Wales University. He attended many manual therapy courses, mainly the Maitland, Mulligan, applied biochemistry, myofascial release techniques. But the Kosmas' main interest is in the sports physiotherapy. That's why he's currently working as an sports physiotherapist in CSKA Moscow basketball team. So currently he is with the basketball team, and I would say Kosmas is having a very good concept. We would like to be in connection with Kosmas for the future things also. Thank you, Dr. Kosmas, for giving your time.
Thank you for having me. So a little bit of introduction on why I chose this topic. I found that the foot joint is one of the joints that has the most global effect on the body, meaning that the way the foot functions can have a direct or an indirect effect in joints that are above as the knee and mostly the hip, which in turn can have an effect in the after joints like pelvis, spine, and even the neck. So this is the main reason I chose to talk about the foot. And the second reason is that the foot is a joint that is often overlooked unless there is a direct injury in the joint. I mean, like a sprain or something. It's hardly overlooked, not hardly, it's overlooked about the effect that can have in any other injury everywhere in the body. Meaning that the latest incident that I have in our team was a player that his glutes were not functioning well. They were not firing up. We were trying to make them stronger, but he could not even undergo a manual test. So after many sessions, I personally found that activating his peroneus muscles and activating his tibialis posterior muscle immediately have an effect on the hip joint and on the gluteus muscles directly. So this one for me once again for me was enlightening about the importance of the foot. Now, beginning on I have to mention that my take on physiotherapy, the approach that I have on physiotherapy, rehabilitation, and treatment is to keep it as simple as possible. So this is the way that I will present the topic today, to keep it the simple as possible, unless an injury or an assessment indicates something different. I always keep it simple. So going to the first slide, one of the main one of the main properties of the foot is the ground adjustment, and along with the shock absorption. We know that in daily activities we hardly ever have to deal with even surfaces, so the ability of the foot to adjust in an uneven ground is very crucial both for the foot of this the foot itself, but as we mentioned at the beginning, for the health of the joints that above the foot. There is a complex mechanism that involves structures like bones, ligaments, joint capsules, and muscles that maintain the ability of the foot to adjust to the ground, and of course to cushion the body, to weight bearing, to have the weight of the body. So it is pretty understandable that we have to maintain the best possible, how do you say, the best possible environment for the foot in order to function properly. There are many things like improper shoes, muscle imbalances, and untrained, sort of saying, toes, and more specifically big toe, that can disrupt the biomechanical advantages of the foot, thus increasing the risk for injury both on the foot and the hip, and of course the above muscles. Shoe type, as I mentioned, like high heels, can have an immediate effect, although we all know that women like to wear high heels. They put the foot in an abnormal shape, thus an abnormal function. High heels, I would say, although it's not referred to athletes, hopefully, for me is the worst thing you can wear as long as we're considering foot function. And of course, we have the foot type. We have several studies that are showing that the foot that's called with a high arc or a foot with a very low foot arc can have an immediate effect on the way the foot accepts the loads and the ground force reaction. So what we have considered is that when we try to pick some shoes, even if we're talking about athletes or we're talking about normal people, we have to pick choose the foot that allows the foot to perform fully. The toes have to function. The plantar fascia has not to be overloaded. So keeping that in mind. So secondly, we have the muscle activation. Excuse me. We have the muscle activation and propulsion. Now, muscle activation. We're not going to analyze the gait cycle and the whole muscle activation during the cycle, because we have a table here that everybody can see about the muscle activation. But as we all know, there are muscles that like peroneus muscles, which along with tibialis posterior are forming a muscle band that supporting the foot when we step, when we are walking. So having both tibialis posterior and peroneus muscles activated, for example, will give us a great deal of balance during gait, during running, during jumping, etc. Now, how are we sure that those two muscles are activated? Well, in the team and in my general practice, there is a method I use called muscle testing that can show you exactly what's going on in the neuromuscular system at any given time. So instead of guessing which muscle could be underactive or overactive, you can just muscle test and see what are their balances in the neuromuscular system. Now we know that different strides may activate different muscles. meaning that there are studies to show that, let's say, runners who use different techniques, runner who uses the rear side of the foot when running, comparing to runners who use the front foot more as a technique of running. Not exactly decompress, I cannot find the exact word, but puts less load on the plantar fascia than those who put weight on the forefoot. So now other studies have shown us that the stride and the speed of walking can also have an effect both in the percentage of the muscles that are deactivated during running and walking, but also the age. I mean, older people activated more muscles, the tibialis posterior muscles than younger individuals in running. So instead of guessing which muscles I have to assess in order to gain a more balanced neuromuscular system, thus a more healthy foot, thus a more healthy hip, thus a more healthy body. The best way to do that, and the way that I found most beneficial for me to help to identify the imbalances is the muscle testing. So this is what I recommend to everybody who doesn't know how to muscle test properly. One other topic that I like to pick is the big toe mobility and stability. The big toe is often overlooked when assessing the foot, and certainly it is overlooked when assessing other joints like a hip, spine, or pelvis, or anything. But it is widely known that if we don't have enough big toe extension, then we have a lot of pressure, let's say, on the knee. There are situations who people doesn't even use the big toe, who is a big propeller of the body. I mean, it pushes the body mainly in the phase of the push off during gait cycle. Is one of the main contributors to push the body forward. So my take on this is assess the big toe, see the extension, see the flexion, see if there's any deformities. That would make a huge difference when you assess the ankle joint. Now, this is one of my favorite pictures because it shows with a very, very distinct way the way the foot position, the foot function, the foot structure affects globally the body. We see here in the picture that a drop on the arc of the foot, a pronation, let's say, causes an internal rotation of the lower limb, the tibia, the femur. It causes the pelvis to drop on the same side. It causes the muscle to be lifted also on the same side. This is, and as you can, for all of you that are into the sports game, you can see that the internal rotation of the knee, okay, imitates the mechanism of injury of ACL, meaning that, especially for you that you are in the sports business, you don't want your athlete to have an excess in the internal rotation of the hip or the internal rotation of the tibia. So, because of course this increases the risk of injury, not only of the ACL, but the meniscus and medial collateral ligament, etc. So, in your assessment, assess the foot. It doesn't matter if if the problem or the demand of your patient or the athlete is a pain in the hip, a pain in the lower back, a pain even in the neck, assess the foot. That is my advice. Now, there is a term for more stability, which was firstly introduced by Gary Gray, who was a physiotherapist at first, and then he was into the training business, which is a synthesis of the two words mobility and stability, which are the two prerequisite for a healthy joint, even if the joint is the ankle or every other joint in the body. Now, as we can see here, the lady, the ballerina, for sure she has more range of motion, active range of motion than you and me or everybody or anyone who's not a ballerina. But that doesn't mean that she's not stable. The reason she's stable is that in this range of motion, in this very, very great range of motion, she is trained in this range every day, meaning that her neuromuscular system has gained strength and power in this range of motion, something that is not normal for you and me. For her is normal. Now, what contributes for a joint to be stable? Well, we have the passive support system, which is consisted by the ligaments, consists of the bones, the joint capsule, and we have the active support system, which are the muscles. And okay, we do not know yet, but the fascia is in the game for some period now, and there is a lot of research going on the function of fascia. But we should stay on the muscle component. Now here we see the passive support system. Okay, here we see the ligaments of the lateral part of the ankle, which are stabilizing the foot. And on our right, we see the bony structures, which consisted by the tibia, the fibula, the talus, the calcaneus, the midfoot with the 5 bones, the metatarsals, and the phalanges. What I want to point here is the importance for every physiotherapist to know its anatomy the best way possible, because this will help him both in assessment and in treatment. Now, let's talk a little bit about the bones and their contribution to both the assessment and the treatment. Now, we have the tibia, which is the thicker bone of the two, and it undergoes a lot of load. Much more load goes to the tibia than the fibula. Of course, this is basic knowledge, but we have to say it. This is more stable than the two bones. And we have the tibia, that is the thinner bone. It's on the outer side of the foot and goes more down. It's longer, let's say, than the tibia, and goes way more down than the tibia. On one hand, this is we have this contradiction that although the fibula doesn't undergo a lot of pressure, that's why let's say fracture in the fibula is not as important and is not as serious as would be a fracture in tibia, although it contributes a lot on the treatment, especially when we are talking about manual treatment. Mulligan says, according to Mulligan, fibula, when we undergo, let's say, an ankle sprain, most of the times, along with the supination of the foot, it gets more down than it should be. The problem is that even though structures like even though structures like let's say an injured ligament can be healed and there is no pain and there's no inflammation and there's no indication of injury anymore on a healed ankle sprain. Many times athletes or just normal people are coming to us and saying that I still have pain, I still have dysfunction, I'm not feeling my leg, my injured leg like the other one who wasn't injured. Now, I have found in clinical practice, of course, Malikan had said that way before me, but I can confirm that in clinical practice, a correction of the tibia cephalad means pushing the tibia up to the direction of the head, can have a very good effect both on pain and dysfunction. Even if we are referring to restoring supination, or we try to restore dorsiflexion or plantar flexion or whatever. Now the fibula, I repeat, in ankle sprains, we see that the fibula is dropping down. So we have to correct it by pushing it up. In many cases, though, there are many cases though that the fibula could be moved anteroposteriorly, meaning with a direction towards the backside of the body, and not very often could have the reverse direction, moving posteriorly to anteriorly. All these directions can be used to assess, to see the joint play of this joint, of the tibiofibular joint, and also can be used to treat dysfunction of the foot. I don't know if I say it correctly, if my English are good, but in general, I would say assess the fibula. For the people that are in manual treatment, manual therapy, this is common sense. But to all the others, guys, assess the fibula. Now, we have the talus. Talus is a bone that is seated between tibia and fibula. There has a movement during flexion and extension of the foot, plantar flexion or dorsiflexion. It goes back and forth during flexion and extension. Sometimes it can be isolatedly be stacked between those two bones, causing the dorsiflexion difficult for the person to be performed. So another point that I would take when I assess a foot is, what is the situation of the talus? Is it moving properly? Does it give the freedom of motion that it should or not? So, after that, we have the calcaneus. Calcaneus is the heel, although in my belief also mistreated. It doesn't. We don't give it the significance that it should. Although, as we know, there are two very strong structures that are inserted in this bone. I'm talking about the Achilles tendon, and I'm talking about the plantar fascia. And it's largely overlooked too. I think I will have a picture over here to pinpoint the importance of the heel in the assessment of the foot and ankle in general. You know, in the picture of the left, there is a player of ours who was complaining about pain on the forefoot all the way during the season. He was complaining, not during the season, at the start of the season, he was complaining that he came back from his national team with pain on the forefoot. The picture on the left is the initial picture, who shows the deviation of the heel. We can see the medial part of the tendon, of the Achilles tendon, that is being contracted, and the outer part that is, let's say, in a stretch position. On the left, on the right picture, we have his heel. Of course, it's not weight bearing, but we also treat him in weight bearing position. But here, the pictures I have is on the non-weight bearing position. We see on the right one, we see the alignment of the tendon. Of course, it's not done. This is after 2 treatments. But as you can see in the second picture, if the heel was not treated properly, he would have a misaligned leverage for the Achilles tendon, which means he would have a high risk of injury in the tendon. And also, since the plantar fascia inserts on the heel, my take on this is that the position of the heel had a directly effect on his pain on the forefoot. After several treatments, 10 or 15, I'm not really remember the number, the player was saying that he felt a lot better. So we continue the treatment, not only on the heel, of course, but the heel was being checked on every assessment. And something else, that since we know the connection, the mechanical connection that has the Achilles tendon with the plantar fascia, since the plantar fascia is carrying the load from the forces that the Achilles tendon produces to the forefoot. This also helped the player not only reduce the risk of injury, but increase his performance in general. So going back to the bones, we have the midfoot bones with the mid-tarsal joint, which is responsible for the supination and the pronation of the foot. Nonetheless important that all the other joints that we mentioned before, supination and pronation restore, can help you a lot when you are talking about foot health. This for me, these structures are the most important that can help physiotherapists assess, help, and restore the function of the foot. Now, going to the active support system. As we said before, the active support system consisting of muscles is the one that makes stable every joint in our body. There are muscles that the peroneus, the tibialis posterior, the antibialis anterior, the gastrocnemius, soleus, and all the other muscles that you see here that supporting both the knee and the ankle, and of course every other joint. Now, the thing is that I found very often that the popliteus, which of course it's not a muscle of the foot, but can have an effect on the foot, has to be assessed equally as all the other muscles that directly move and function the foot. The thing is that the reason is that the insertion of the popliteus muscles in on the inside part of the tibia, right under the medial condyle. And if we have a spasm, let's say, in the popliteus, then we would have an internal rotation in the tibia, which in turn would alter the biomechanics on the foot, which in turn, as we're going to repeat again and again, can have an altered biomechanics of the hip and the body in general. Now, we're gonna go again and again in some things that I found important in my practice. As I said before, there are things we know from the studies, like that the peroneus muscle time of reaction can play a vital role on the ankle strain and the lateral stability of the ankle. But the thing is that we have three peroneal muscles. We have the longus, the brevis, and the tertius. In general, they have a similar function. But how do I know which one should I activate? Should I strengthen to have a healthy joint? How do I know which one of them is overactive or underactive? And how do I know that the muscle that is underactive, let's say peroneus longus is underactive because of an overuse, or is underactive because of hyperactive tibialis posterior? Well, again, my advice is test and retest. There's no other way for me. I mean, guessing, if you're lucky, yeah, you can find it. But instead of guessing, you should muscle test, because especially after every injury, we have something that's called Autogenic Inhibition. I'm sure you are all familiar with that. That causes the muscles to be inhibited in order to protect the joint of not moving too much, in order to prevent a further injury. So after, let's say, after the first stage is that you might use physical modalities. I don't use physical modalities. But let's say that you do. After the physical modalities, when you try to restore the strength on the foot, how do we know which muscle should we strengthen? Okay, we can have a program that includes balance board or banded supinations and pronations of the foot, etc. But let's say that we do the pronations. We try to activate the peroneus muscles, and we do the exercises. But the result, if the result is the exact one we want, it remains a mystery, because if you do a muscle test, you never know. And let's say that the peroneus longus is active and strong enough. So, but the peroneus brevis or the peroneus tertius is underactive. The movement will be performed from the muscle that is dominant. So in reality, we would continue to strengthen the longus, but the other two that are less dominant probably will remain underactive. So in order to have as we know, because there is an interdependence on the function of every joint, in order to have the interdependence, I mean, one muscle helping the other to do the proper movement, you have to be sure that there is an independence in muscle strength. I don't know if I'm saying clear, but what I'm saying is that if you have a pattern which is performed by a muscle from the outside, you can say, okay, the movement is good, but from the inside, if you dig deep, you'll see that in the place that all the three peroneus muscles should activate the pronation, only the locus does it. So test, muscle test, do your exercise and test again. Here we have some functional tests that we use for the foot. I find the wall test very useful to assess the dorsiflex. We have the test for the plantar fascia, and we also have the star excursion test, which also is a very good test and exercise at the same time to see how our ankle joint performs, and in weight bearing position, and in on a multi-joint demanding exercise. So plantar fascia, very strong collagen collagen tissue that supports the arc of the foot, especially in sports. Many guys at least once a year comes for pain on the plantar fascia. It carries as much as the 14% of all the load of the foot, and as we said before, it transmits the forces from the Achilles tendon. On the picture on the right, you can see the mechanical connection, and in my belief, you can understand the importance of the calcaneus bone. I mean, the alignment of the calcaneus bone. That and remember the picture that we seen previously. So I would say if you have a pain in the Achilles, dysfunction in the Achilles, treat fascia, plantar fascia, and assess the heel bone. If you have a pain in the plantar fascia, assess also the Achilles and the calcaneus, the heel bone. Now we're gonna do a quick. We're gonna be informed very quickly about the ankle injuries, and especially about lateral ankle sprain, which, as you can see on the right, it's more dominant in the women than the men, and it's very often in indoor sports like basketball, handball, or volleyball, etc. Now here I have statistics of the period 2018-19 from our team. You see the absolute dominance of foot and ankle injuries, with 54% of all injuries being in the foot and the ankle, which is huge. An NBA 10-year study showed that the 55% of the stress fracture are happening on, as you can see, on the fifth metatarsal and on the ankle and the fibula. Now, residual symptoms. We got chronic ankle instability, which could cause 30% re-injury chance, meaning that chronic ankle means that it doesn't, the assessment and the treatment doesn't stop. Let's say if you have a second degree or first degree ankle sprain, doesn't stop in the time frame that the protocol says. We have studies have shown that second degree sprain could take from up to 1 year to be back in its normal function before he get injured. Now we have mobility restrictions, as we said before, limited dorsiflexion. Very, 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 very important on treating ankle sprain is restore dorsal ankle flexion. As we said previously, check the talus, check the fibula. I find it very useful in manual therapy, mobilizing both proximal and distal tibiofibular joint, and treating manually with mobilization with movement the talus during performing dorsiflexion. We've got postural control. We've seen before in the previous slides that the effect that can have an injury, a foot injury, is global. So this could, as the slide says, could take up to 6 months in order to restore postural control. And of course, we have the strength loss in all the muscles of the foot, but the hip also, because as I told you in the beginning, the most immediate effect that I've seen by treating the foot and the ankle was on the hip function. So we're not referring only to the strength loss with the foot, but the hip in general. And I assume we can all agree that this is very, very risky for re-injury, let's say. So lateral ankle sprains, loss of strength in inversion and inversion. Patients return to sport before strength restoration. This is very common for us and for you, that is on the sport business. The coach needs the player very early. You know that the player shouldn't start. You should find the golden solution to this. My take on this, the proper solution is strength, exercise, test, exercise, and test again. So we have here a table that shows the effects that can have an effect, can have an ankle sprain on the range of motion, on the strength, on the postural control, and the functional task. For me, as a manual therapist, the most important things are the decreased range of motion. Before everything, you have to restore the strength, the range of motion. And even now, to go to another subject, even if there is a guy that is not injured, but he lacks of range of motion in dorsiflexion, plantar flexion, supination, or whatever, or even if the athlete is injured, but he was injured 1 year, let's say 1 year ago, and he has lost his dorsiflexion, and for some reason the physio didn't restore the dorsiflexion. Now, when he comes to us, my perspective on this is that first you go to restore the range of motion, but the tricky part on this is that his neural system, his central nervous system, and his neuromuscular system has been trained the last year to have the strength in a particular range of motion. Let's say that his range of motion in dorsiflexion was only 15 or 20%, and his dorsiflexion was 20%. Now, if you increase that by 5 degrees or 10 degrees, this is good because the motion has the mobility that is proper for the athlete. But the tricky part is that he is not trained in his new range of motion, which is a very risky thing. So my opinion on this is that each time you help an athlete or just a patient to restore or to increase range of motion of a joint, you should immediately try to train and to strengthen this joint in the new range of motion. Otherwise, it would be, let's say, like you have created an unstable joint, which it's not a stable joint, it's just that this new range of motion is not familiar with the CNS, with the central nervous system and the neuromuscular system of the athlete, of the patient. So if during any activity he reaches this range of motion, normally he wouldn't have any strength, so he would be at risk. So long story short, if you help a guy restore the range of motion, help him immediately at the same time to gain strength in this new range of motion. Now, the second pathology that I would like to talk a little bit is something called hallux limitus or rigidus, which is a condition of the first metatarsophalangeal joint. This is a degenerative condition which causes, you can see in the right picture that there is a very narrow space in the first metatarsophalangeal empty joint. So we have a decrease both in extension and in flexion. Of course, there is arthritis depending on the severity of the pathology, the degree of the pathology. Here, I'm going to show you a video with stage 4 hallux rigidus. So we have a loss of range of motion, loss of motor control. We have arthritis, and we have cartilage degeneration, big time. Usually, when a patient is in this stage, which is stage 4, surgical procedure is the proper one to help him. But what can you do if there is a high-level player and it costs $1 or $2 million, and you cannot afford to have a surgery during season? Well, what you have to do is, as I said before, you've got to increase first of all the space, increase the range of motion, and strengthen the big toe, strengthen the other toes, and re-educate the nervous system to use the area, because as we know from the Autogenic Inhibition, there is let's say, a lack of communication between the injured part and the brain. So, as you will see in the next video, the athlete was asked, with the pathology of hallux rigidus, was asked to perform toe flexion and extension. I will show you the first video right now to see that he cannot even understand what I'm asking. You see, he cannot even have the control of the toe. So let me show you what I mean. So as you can see, I'm asking him, okay, flex and extend your toe. No control. No control. He just moves his ankle, and he has the ability of flexion, but it's on the phalanges. It's not on the joint that we want. Let me show it to you once again. See, he cannot even comprehend what I'm asking. He cannot move his big toe. He's moving the ankle. He's moving the toes. No extension. some flexion only, but it's not exactly at the joint that we want. It's on the phalanges. So next video is after 2 sessions. Same thing. At least here, not much of progress, but still, you see, he can understand. He tries to extend. He's moving. He's moving. He goes up. Let me see. Let's see this once again. Flexion, extension. He understands. He's got motor control. This is the second. I think it's the second session. As you can see, there's a bunion and there's a calcification on the foot. Here is after 4 sessions. In my belief, this is much better. Of course, it's not perfect, but the athlete, his subjective opinion is that I feel much better. I can train better, and for me, this is good. So the thing that we did to this player was we just tried to create some space in the joint. We decompressed the joint, and then we tried to strengthen the new range of motion of the joint with exercise. And last but not least, it's plantar fasciosis. I'm pretty sure almost all of you have experienced a case of plantar fasciosis in your clinic. So the thing is that nowadays it's no longer plantar fasciitis, because it is reconsidered that the main problem with the plantar fascia is not the inflammation, it's the degeneration of the collagen in the specific area. So for sure, sometimes there is inflammation. You can use physical modalities, you can use whatever you're comfortable with, but my perspective on this is that once again, you got to lose the soft tissue. You got to move the calcaneal bone. You got to move the rear foot. You got to move that metatarsals. You got to restore the mobility periphery. I think the joint is the word is periphery, in the periphery, and eventually the plantar fascia will loosen up. And of course, I said before, whenever you have to treat plantar fascia, I would first assess the calcaneal bone and the Achilles, the calves. So, as I told you at the beginning, I'm trying to keep it simple. This is my opinion, my brief opinion in how to treat dysfunction of the foot. To summarize, I would assess the bones first. I would mobilize the bones. I found the mobilization of the tibia, of the fibula, very useful in any direction, anteroposterior, posterior anterior, caudal or cephalad, or whatever. What I forgot to say is that not very rare, but not very often too, I found that especially after surgeries, because we had a couple of these this year in the team, we have something called diastasis. Diastasis means when the two bones, fibula and tibula, are getting far from each other, with the movement, of course, it's very, very small. But as the two bones, due to the ligamentous instability and the osseous membrane instability, as they are placing each other more far than they should, the athletes came in the physio room and they are complaining about pain just behind the medial epicondyle. So, in my personal experience, I found that pushing those two bones to each other, pushing them towards each other, and having him actively on weight-bearing position do high heel raises is a very, very, very good effect. This is my opinion, my clinical observation. I don't know if there is a study who can back what I'm saying me up, but this is my take. So assess the bones, assess the alignment of the bones, assess the heel, the talus, and one of the most important things and most helpful things that I have ever learned and do in my daily clinical practice is muscle test. Don't guess, muscle test. You gotta know where is the imbalance. That is all for today. I hope you find it useful, and will be more than happy to answer if there is any question. And that's about it.
Thank you, Kosmas. It was a really wonderful session, and people have enjoyed very well. There are a few questions here I would like to ask you, what the audience has put up here, that is there any advantage of being barefoot over shoes? And if so, are we really promoting barefoot? And if it is not advisable, then what kind of shoes one should put on?
So on the barefoot thing, there is a trend now in the training, especially in the weightlifting part, to do training stuff barefoot. As far as I know and I've seen, there is no benefit that would be so huge in order to make someone to go barefoot. Now, if we're talking though about walking, my take on this is yes, whatever lets your foot biomechanics applied properly. Yeah, I would do that for sure. Yeah. And about the shoes, the shoe thing. My opinion is the same again. Whatever makes your foot functions properly, I'm with it. I don't like shoes with hard insoles that are rigid and are not letting the foot and the arc of the foot be performed properly. So I would say light shoes. Okay, in general, this is in general. There are ways to test exactly which pair of shoes is ideal for you. But this is a subject that we teach to people on a seminar. But there is actually a way to know which exactly shoes is better for you.
Yeah, very briefly, can you just highlight few points how we go ahead with the test prescribing shoes? Very briefly, if you can have just idea. I know that this is the
good. Well, for sure. I will tell you my experience and what I'm doing most of the time, because sometimes people are when I do this are looking at me like I'm a crazy guy when I'm shopping. So, are you familiar with applied kinesiology?
Applied kinesiology, yes.
Good. Well, there is a test that you wear both of the shoes that you want to buy. Let's say you like Adidas or something or whatever. You wear the shoes. You place, let's say, the left foot in front of the right, like when you walk, and you extend your right arm. So you got the two opposites. You got the left foot and right arm extended. Now, if you muscle test the arm is extended. Okay. If you go and muscle test it, if the hand remains strong, it's an indicator that this might be good for you, but you should do it in both sides. So I don't know if I'm being very general or confusing. I don't want to be confusing, but there are ways that are coming from applied kinesiology that you can use to choose a pair of shoes.
Yes, I got your point.
This is a
Like
very good
we can
idea
use applied kinesiological principles to choose the right kind of shoes, and definitely I think it is working on stability. If your base is very stable, definitely your
Exactly.
yes, yeah.
Because let's say now, to say very generally, don't want to confuse and be in many details. The way you step, the surface in the ground or the shoes that you are stepping on, your foot that is in these shoes are sending information upstairs on the brain. Now, if the brain receives something as, let's say, threatening, it's not threatening, but it's not comfortable for the body. What happens is that it kind of inhibits the nervous system. Not completely, but I think you know what I'm trying to say. So you can take this information, but just by muscle testing. That's something. Okay, it's not scientifically backed up. There are no studies about it. It's right on the edge of science and alternative medicine, let's say. But okay, it can do no harm. I'm using it.
Yeah, there's one very curious audience has asked that how big toe can remain weak since we are putting more weight on the great toe every time.
Come again?
Like what I understood about this, he's asking that we are putting more weight on great toe, right? So when we are using frequently, how it can becomes weak, as you said.
But it's not used frequently. One of the things that it amuses me every summer is that if you notice, especially the girls, I don't know why, but in women, especially the girls, if you notice them walking, you can see that most of them, they are leaving the big toe up. They're not even putting it down. They're not using it, and I found it. I'm just telling you my personal observations, okay? But if you see girls or guys who has an external rotation of the hip, I mean, they step like this. They don't even use the big toe. The problem is, the thing is that if they use the big toe would be strong.
If you are using big toe,
they could be strong for sure. There are exercises that we use. Guys that are on the track and field, the runners and stuff, they have a specific exercises for the toes. So, because
great, Dr. Kosmas, you have explained very well. Dr. Sagul is there if you want to add anything.
It was a great session, Dr. Kosmas. Definitely, we would take away messages. We should mobilize the fibula. We should go for the good muscle testing, and there is a great role of the big toe. And definitely, means,
big toe. Use it or you lose it.
The huge role is there, and if we just train the big toe is having the full flexion and the extension, then definitely there would be a good change would be coming up.
Yes, of course.
Yeah, we would be wishing up more and more lectures from your side, because you are a basketball expert, physio experts are there. So in the next lectures, we would be wishing you should teach us few techniques on the foot, how to mobilize the fibula, how to go for the talus movement, and how we can go to, if you got time, so we would be inviting you for the further lectures so that we can discuss further onto the how to improve your foot biomechanics.
For sure, I would be more than happy. Use it, and as a closure, test, retest, use it or lose it.
Okay,
That's my take.
So
thank you
for
Dr.
your
Kosmas.
cooperation.
Thank
From
you for your
our
time.
country, we say gratitude to you. Thank you. Thank you. Thanks.
Thank you.
Thank you so
Thank
much,
Take care.
Kosmas, for
Take care.
being on this platform, and the audience has definitely got benefited with you. And definitely in future, we will have you many more times. And thanks to all the participants who are listening to Dr. Kosmas, and thanks a lot. Thank you.
Thank you. Take care.
Thank you.
Thank you.